Greetings and welcome to today's On With Life webinar, Inpatient to Outpatient, Real-Life Applications Across the Spectrum of Rehab. My name is Dave Clark. I'll be your host today. This is the 8th webinar in our series of stroke rehabilitation webinars. If you missed one of the earlier webinars, all of them are available on the On With Life website. There's no cost to view any of the webinars, and each webinar is good for 1 contact hour of continuing education credit. After you viewed a webinar, all you need to do is complete the evaluation form and you'll receive your certificate. All right, well, let's get started with today's presentation, Inpatient to Outpatient, Real-Life Applications Across the Spectrum of Rehab. And let's begin by meeting our presenters. Carla Dippold is Director of Case Management at On With Life. Carla joined On With Life in 2006. She has over 35 years of rehabilitation nursing and case management experience, and she's had experience with both pediatric and adult populations across the healthcare continuum, including the acute hospital setting, post-acute rehabilitation, outpatient, and home health care. Carla's clinical background is comprised of experience in neurological and neurosurgical populations, trauma, orthopedic, and medical surgical, with a focus on brain injury, stroke, and spinal cord injury. Carla is certified in rehabilitation nursing, case management, and as a brain injury specialist. Tammy Miller is Director of Outpatient Services at On With Life. Currently in her 22nd year in the rehabilitation field, Tammy has had the opportunity over the years to work with a multitude of practice areas, including brain injury and neurological disease, geriatrics, pediatrics, home health, post-acute, long-term care, outpatient, and mental health. She's received additional certifications as a certified brain injury specialist and certified case manager, and has completed her Master's of Science in Health Science with an emphasis in leadership. For the past 15 years, Tammy has been working at On With Life, focusing on brain injury and neurological rehabilitation. So Tammy and Carla will lead us through the rest of the webinar, and with that, I'll turn it over to the both of you. Tammy, Carla, take it away.
Thanks, Dave. So we're going to go ahead and get started. This is Tammy, and I'm just going to start with saying that at this time, Carla and I have no disclosures to share. And just touching base on the overall objectives for our webinar series, and that was that we hope that by the end of this series, the participants will be able to generate an increased understanding of the various areas to address following a stroke, that they'll be able to identify the importance of engagement and rehabilitation, and they will also demonstrate proficiency with basic stroke rehabilitation interventions. So we're going to go ahead and get started. I'm going to throw it over to Carla to talk about our transition decision tree.
Thanks, Tammy. As we talk about applications across the continuum today, we want to just review that most individuals with a stroke diagnosis are originally seen in the emergency room. They then transition to either an intensive care unit and onto a medical neuro unit, or go directly to the medical neuro unit from the emergency room. During their stay in acute hospitalization, many specialists are consulted into cases to look at their neurological status. A neurosurgeon may be called in, a physician that specializes in physical medicine and rehabilitation. And really the key question during that stay is, are there ongoing medical needs that require daily physician visits? If they do require a daily physician visit because of their medical status, they're going to transition directly to either an LTAC for continued acute care or an acute inpatient rehabilitation unit where a rehab physician will see them daily. If they don't need that daily physician visit, then they can transition on to other post-acute rehabilitation programs, inpatient, outpatient, inpatient skilled nursing facility, I should say, outpatient, therapy services, home health care services, depending on their status. We're going to go back and focus on acute hospitalization for a moment. And the focus initially is on diagnosis and medical stabilization. Not only are they treating the effects of the stroke, but they're also looking at comorbidities. So let's take that apart just a little bit. One thing is they're finding the diagnosis. Did they have an ischemic infarct? If so, they're looking at that window. Do they need TPA, and can they receive TPA? If it's a hemorrhagic stroke, usually a neurosurgeon is called in to decide, do they need medical intervention to evacuate that clot? And so they may go right in and have a craniotomy to have that done. A lot of the folks that we see are severe enough that they actually have to have a craniectomy where part of the bone is removed to allow for recovery for the swelling that's taking place in the brain through their hospitalization. They also look at comorbidities. When you have an injury to the brain, it affects everything. So it affects premorbid status of your hypertension, ability to control that, diabetes, cardiac issues. All kinds of things are affected when the brain is affected. Hospital stays are short, we know that. They're really trying to stabilize the patient so that they can move on to the next level of care. So they're looking at things like, what is their nutrition status? Are they able to eat? Do they need to put in a G-tube? They want to make sure that they'll have adequate nutrition moving forward. They're looking at bowel and bladder function. Are they incontinent? Do we need to put in a Foley catheter right now? They're not moving. We're worried about the medical status, not getting someone up to allow them to do toileting, especially if it's difficult. If their stroke is severe enough and they have enough lines in, that would be hard to get them up. They look at behavioral management. Is the person restless, agitated? Do they need medications to help calm them? Are they having difficulty sleeping? Are they depressed? Again, medications to help them through that initial stay. Are they having pain? Lots of times they'll receive things like oxycodone to calm the pain that they're having, which also feeds into that restlessness that they might be exhibiting. Did they have a seizure? If so, one of the most common medications we see put on board is Keppra to help them with that. So really just looking and focusing on stabilization and getting them ready for the next level of care that they're going to go to. There's also a therapy component. I'm going to pass this back to Tammy to talk about that.
So from a therapy standpoint at this stage, there's usually not a ton of therapy happening. It's usually a short stay at this stage. They're getting in there and doing a basic evaluation and intervention. They're assessing where that individual is at that time, what the difference from baseline is, but it also gives a good baseline of where they're at now as well. They're starting, if they're getting time to start some therapy, they're starting with those building blocks of rehab. So this could include just basic as being able to sit up, working on that endurance. Where are they in terms of midline? Are they leaning one way or the other? Are their vitals staying stable when they go and get them up in the chair? That sort of thing. When you think of those building blocks, those things that you have to start with to be able to build up to being able to do some tasks, you start with like building blocks of mobility. This would be like sitting edge of bed, working on those basic transfers. It maybe is going from laying supine in a bed to sitting up edge of bed, and then from edge of bed to the chair at bedside, that sort of thing. They might be beginning some basic standing. So even just going from sitting on the edge of bed to standing for 30 seconds might be the goal at first. And then depending on how they're doing and what they're tolerating, maybe even some starting ambulation again. From an ADL standpoint, they're also getting in there and working on those basic building blocks such as dressing, grooming and hygiene, toileting. But again, it's very basic stages, and usually it's for a short period of time at this stage. Additional areas that need to be addressed, even as early as the ICU or during medical stabilization, is that we need to be monitoring for positioning to prevent any long-term issues, pressure areas, those sort of things, maintaining range of motion and managing spasticity. In addition, during this time, there's usually from a speech therapy standpoint, there's a basic swallow evaluation that will take place at bedside as well, to help assess safety and need as well as communication. Speech could be stepping in to assess the best way to communicate and how reliable those answers are at that time. So really as we move into these barriers of what to anticipate and prepare for. There's lots of things happening at this stage. And Carla, do you want to go ahead and talk a little bit about some of those barriers?
Yes, thanks, Tammy. You have to remember that having a family member who's had a stroke is probably the worst thing that these families have ever endured unless they've had a close death in their family. This is devastating to them. Their whole life is changed in an instant. The person that they knew and loved is radically sick, may not even live, they've been told for a while. And hopefully, as we move on to the next phase of this discussion, they've heard they have lived. So they're going through a roller coaster of emotions. They have finance issues still at work. They have other family obligations they're trying to juggle. They're not sleeping. They're having to make life and death decisions. Do we put them on the vent? Do we not put them on the vent? Do we put in a feeding tube, not put in a feeding tube? These people are very, very fragile, and making medical decisions is very difficult for them. They rely a lot on the professionals and look to them for guidance. And often when we see folks later, they often wonder if they made the right decision at the time. They might be getting mixed messages from all the different specialists that have been called in. So it's just very confused. We know they're not retaining the information that we're giving them. They're getting bits and pieces of it, but they're just struggling as family members with just the whole medical instability situation and every single decision that they have to make as their loved one lives in the balance in the hospital. One of the other things that we want to talk about is endurance. Do you want to jump back to that, Tammy?
Sure. One of the big things that we struggle with at this stage is the endurance of the person served. So because of everything that medically has happened, there could be so many things playing into what they're able to tolerate at that stage. And because of that, and what they can tolerate, and both medically and psychologically and everything that's going on, planning that next step or that next transition is difficult. So you're constantly at this stage having to assess where not only the person served is, but the family as well, and preparing everybody for that next step in transition. Now that could be to another rehab, it could be home health, it could be outpatient therapy. And the difficulty with that is that it's ever changing at that point. Like based on how they're doing day to day could determine where they could go at the end. And so it's an ever changing process. It's also preparing them for this isn't the last step, and the next step is probably not the last step. It's changing through different levels of care. They're not going to be in the same spot for their whole recovery, and helping them understand that this is just the way the process works and where we go. Anything else, Carla, that you can think there?
No.
Okay, so we're going to move on to the next slide. And on this slide, we're going to talk more about the inpatient rehabilitation level. So they've transitioned from acute to inpatient rehab. Carla, I'll let you talk a little bit at first about the medical management that is taking place at this stage.
I'd be glad to. Looking at the medical management of a person, they're hopefully stabilized at this point. So we've gotten through acute care in that process, and now we're just looking to manage them, keep them well. Our medical staff here at On With Life often says that they try to keep them as healthy as they can so that they can continue to participate in therapy and reap all the benefits of that. So let's talk about dysautonomia for a moment. Most of the people that we see have dysautonomia at some level or another, even if someone with a minor stroke, if you can call a stroke minor, may have difficulty managing their blood pressure, and may not have even had blood pressure issues prior to this. So if their blood pressure is high, our medical staff usually starts something like a beta blocker like metoprolol or propranolol to help with managing blood pressures. If we're running low, they tend to give something like midodrine to help with that. Also give compression hose, things like that. I'm just going to take you through some body systems here as we talk about medical management. So we're going to move on. I do want to note that we usually start everyone on a blood thinner. They're not moving as well as they used to. They're either in a chair or laying in bed. So they're at risk for blood clots. So we usually start them on either Eliquis or Xarelto, so that they don't have to have as many sticks to draw blood. With Coumadin, which is the other choice, they have to have regular blood draw so that they can manage that dosing. So one of those medications are used. One thing that we always think about is, what does their balance look like? What's their level of confusion and mobility? Because if they are able to get up but their balance is bad, or able to get up but they're confused and their balance is bad, we tend to not use Eliquis or Xarelto, because with Coumadin, at least you can give vitamin K if they do fall, which will decrease their potential for bleeding. We put edema wear on folks to help manage their vascular system, to get blood flow back, no pooling in the legs. And our rule of thumb is, when someone can walk up to 200 feet 7 days a week, then we could take them off the blood thinner. They don't have to be on that forever after their stroke. We look at bowel and bladder management, just to go to another system here. And we don't tend to start medications right away. If a Foley catheter was placed in acute care, which I mentioned, we tend to take that out right away, unless there are issues with their skin or they're just not able to urinate. We try to give them time for their body to regain function again before we start aggressively trying to manage like bladder function with medications. We want them to be able to communicate if they're having speech difficulty. We want them to be aware that they are having to urinate. We want their ability to transfer to improve, so that we can actively working on them letting us know that they have to go to the restroom, and getting them on and off a toilet for practicing that. We do bladder retraining. We do self-catheterization training eventually, but that's a ways down the road as they get better. We actively monitor their skin. They are less mobile, that we just talked about. They're sitting in the wheelchair, laying in bed. There's pressure on bony areas. They may be incontinent. They may have splints or braces that can cause pressure irritation. So regularly, every shift, we're looking at that. And then every week, we have a skin nurse that checks our folks from head to toe to monitor their overall skin integrity, just in case there's anything that's missed. We put folks on pressure relieving mattresses, use cushions in wheelchairs that are pressure relieving, and of course treat any wounds or irritation that does appear. Pain management is something that we really look at here. If folks are in pain, they're not going to benefit from their therapy, which Tammy will be talking about in a little bit. For neuropathic pain, the medication of choice that we usually use is gabapentin, although there are others like Lyrica. We also use Tylenol, ibuprofen, Oxycontin, Tramadol, those kind of medications. But for neuropathic pain, gabapentin is the medication of choice. We're also treating tone, and Tammy talked about how important that was to start working on management of that from a therapy standpoint in acute care. That continues over in a rehabilitation unit. Besides the therapeutic interventions and therapy, we give medications like baclofen orally. We do Botox injections. We consult a physician that can do that. And Tammy may mention that in the therapy component. And also we've looked at placing baclofen pumps, which gives that medication intrathecally to folks to help manage melatonin. And we know that that's more effective in the lower extremities than the upper extremities. We have people that are at risk for seizures. After you had a stroke, you are at risk. Well, any type of brain injury, you're at risk to have a seizure. If they haven't had a seizure initially when they're in acute care, they really don't have to be on medication. If in acute care they were on a medication, Keppra and Dilantin are some of the big ones that are used, but we can wean if someone didn't have a documented seizure and they were started on it just preventative in acute care. So we're really looking at, do they need that medication? Was there actually a seizure? And we try to get them off those medications if we can. We also look at how well they're sleeping, because if they're not sleeping, again, it's going to limit their participation in therapy. One of the medications that we use most often is melatonin, just to help folks with sleep. We've also used trazodone, which is really an antidepressant that really helps with sleep. We've looked at Remeron before. We don't use that very much because of the effect it tends to have on folks' diets. If people are impulsive and eating a lot, we don't want to put them on Remeron because it tends to do that, make people want to eat, and then they'll have excessive weight gain. But we do sometimes pick it if people aren't eating really well. If their appetite is low, we'll put them on Remeron so that it will improve their diet. Another thing that we look at with all of our folks is doing an overnight pulse oximetry test. We want to know how good the quality of their sleep is. If their pulse oximetry test is dropping below 90%, we tend to get a consult with a sleep specialist to see if we need to pursue investigating sleep apnea. If the sleep specialist thinks that we do, we tend to have a home sleep test that is done here at On With Life, and then they go back to that physician to see if CPAP therapy is needed to help keep their oxygen levels higher. And we've seen great improvement in their alertness and their ability to participate in therapy after treating their sleep apnea. Again, looking at nutrition, we talked about how that starts in acute care. We obviously administer tube feedings if they need it. We work very closely with the speech language pathologist from a nursing standpoint and the dietitian about what kind of diet they're on, adjusting that tube feeding. Do they need a medication to help with tolerance of tube feeding? Obviously, there's lots of teaching of the family and the support system on G-tube site care, administering tube feedings, administering medicines, how to modify diets or liquids so that they can participate in those cares either while they're here, while they're on pass, or eventually for their discharge. And we'll talk more about that later on the slide. Medication overview. We work with them on treating things that they had before or new developed things, such as diabetes. We'll bring that up. Some people need still insulin or are on insulin. They didn't need it before. So we're looking at, can we actively reduce that? Can we get them transitioned back to oral medication? Our goal is to get them as close to the plan of medication management that they had to use before. Oral medication that we use most is metformin, although there are others like Januvia and glyphoside. We teach families or the person themselves how to check their blood pressure or blood sugars. They have a glucometer at their bedside here. We teach them how to draw up and administer insulin, and a lot of that is in conjunction with the therapy team as well. We look at that depression that we talked about in acute care. Do they need medication for that? Some of the meds that we use most often are Celexa, Lexapro, Zoloft, which helps with anxiety too, Cymbalta, which also helps with pain if they're having that. For anxiety, we often use Klonopin. It's a longer acting medication, or Ativan, which is a shorter acting medication for anxiety. To help folks focus sometimes, which can be an issue after any injury to the brain, we often will trial amantadine or Ritalin to help them with that. Let's see, neurostorming or dysautonomia. For our more severe folks that are showing things like increased heart rate, increased temperature, increased tone, increased sweating, they look very uncomfortable, it looks painful. We mix a cocktail, and our physicians often say we're treating the symptoms of the dysautonomia. So whatever symptoms they're having, they'll put a medication on board to treat that actual symptom. So for example, if their heart rate is high, we'll probably put them on a beta blocker, which is something like metoprolol to help manage that heart rate and decrease it. If their temperature is high, we might give them Tylenol just to break the temp at the time. If they look very anxious, we might put them on Klonopin or Ativan. If it's tone that we're treating, again, Klonopin is a great medication, and we also use bromocriptine. which affects the dopamine. As they get better, as we see those neurostorming or dysautonomia symptoms decrease or be gone, after they're gone, we start inching back on those medications because our goal is to get them off as many of those as we can before they transition out of an inpatient rehab unit. Nursing care and education. The nurses work very closely with the rest of the team to educate on diabetes management. We talked about that, how to check their blood sugars, how to give their their insulin, how to drop their insulin, how to give their medications appropriately. We do a lot of education on management of blood pressures, blood clot prevention, cholesterol management, weight reduction, smoking cessation. If you're seeing a trend here, it's really things that might prevent a second occurrence of a stroke. And then before someone leaves On With Life, we really look at what's that ongoing care from a nursing standpoint look like. How does that affect their next step for their recovery that Tammy talked about with the transitions? So we're setting up all kinds of appointments with primary care physicians, rehab physicians, any of the specialists they saw or need to see. So neurosurgery, neurology, cardiology, ENT appointments, vision appointments, neuropsych testing appointments, just all kind of continued care is what our nurses would set up with them. And the importance of follow-up with that care, including getting your medications and taking those regularly. So I'm going to pass it off to Tammy to talk about the therapy component and how that fits with this.
Thanks, Carla. So as Carla was talking, I just realized the complexity that is happening at this stage. There's lots going on as far as the rehabilitation, but also in preparing and preventing future strokes from happening. So those were great outline of kind of the things that we're particularly addressing at this stage here at On With Life. So from a therapy perspective, we also have a lot happening at this stage as well. So typically at this stage, if somebody has been transferred to inpatient rehabilitation, it's because they are requiring or are needing 2+ core therapies at that point. So whether that be PT-OT speech, whether it be PT-OT, to come to On With Life, they're typically complex enough or severe enough that they're requiring all 3 therapies, core therapies in their rehabilitation. But in addition, there are all the other components that go into it. So yes, you have these core therapies, but as we all know, transitioning back to the lives we were living before, there's a lot more than that going on. So in addition, we also have music therapy, peer mentor, rec therapy, groups going on that are extending throughout their day. And here at On With Life, one of the things that we have is the Rehab 16 concept. And what's happening and the focus that we have is we're looking at every day is rehab in somebody's life. Like all day, every day is their rehab. But our Rehab 16 is based on the 16 hours that you're awake, and then you have 8 hours of sleep every day. So when they come here, they're not just coming for the PT, OT, and speech. They're coming to work on all these skills all day long so that they can get back into their daily life. So think of it as every intervention they are offered, every interaction, every transfer, every daily care. So every time they go to the bathroom, every time they wheel down the hall to go to lunch, whatever the case may be, that's an opportunity for rehab. And so while formal therapy is still happening at 3+ hours a day, 5+ days a week, this informal therapy or this Rehab 16 concept really is happening 24 hours a day, 7 days a week. And that's going to help transition that recovery that much faster. So one of the big things that we really strive for is, and have found to be the most beneficial for our person served, is to get them engaged in their therapy. So focusing on striving our therapy to those goals that they have identified, what's important to them, what's meaningful to them. During that time, we're continually addressing any issues that might come up from day to day, but we're also assessing baseline and noting that progress and changes from day to day as well. And when I talked under the acute hospitalization stage, we talked a little bit about those building blocks, so things that are happening initially right after the stroke. So those building blocks are continuing to happen, but we're progressing forward. So we are now, instead of just being able to tolerate to go from supine to sitting, we might be doing sitting tasks at a mat with decreased assistance for a set number of time, and trying to increase that endurance or that tolerance to sit longer the next time. Or now we're adding, instead of a static sitting activity, we're adding a dynamic sitting activity. So again, we're building on each of those each day, each session, to progress them forward. During this stage, like Carla talked about, the vitals oftentimes can be inconsistent. So there's a lot of vital stabilization happening, that dysautonomia that's happening. So really monitoring that, but also getting that body back used to doing these things again and working through that. So it's a lot of collaboration with our nursing team, physician, therapists, to get that person like just approaching them as a whole person and figuring out what we need to do, what medications, how they're responding, that sort of thing. Again, those building blocks for mobility are addressed. So this is when we're really starting to look at how can they get from one place to another. It could be starting with just being able to tolerate sitting in a standard wheelchair. And then being able, the next step might be them moving that wheelchair on their own. So how are they propelling that wheelchair? Maybe then the next step is working on standing, and it might start with static standing to just be able to tolerate standing, and then moving to a dynamic standing task. And then adding on that ambulation. Again, as you can see, it's just adding an additional building block to each task to make it more and more challenging, and also improve their overall tolerance and ability to become more independent. Typically during this stage, we are transitioning back into ambulation, and that might start with ambulation with an assistive device of some sort that requires more assistance at first, transitioning to the least amount of assistance needed, or the least amount of device needed. And then typically also happening at this stage is more focus on those activities of daily living. So the dressing, the grooming, the hygiene, the toileting, showering, those basic ADL skills that they're going to need to be able to complete at home as independently as possible. So when I think of things like dressing, the OT might be in there working specifically on teaching one-handed techniques in order to be able to dress. And the idea with all these tasks is, how do we make the individual as independent as possible? How do we give them that sense of purpose back? How do we help them feel like they're making the progress that they need to be able to go home? And so sometimes those things can be so frustrating at this stage too. They're frustrated that it takes them 3 times as long in order to put their shirt on, or they have to have somebody help them get to the bathroom, those sort of things that we all kind of take for granted when we can do them. And so it's working with individuals, like I feel from an OT background, that I can give people a lot of dignity back once we can help them be able to do those things, like to complete their own pericares. That's usually huge for people. They usually get a relief when they don't have to depend on somebody else to do that for them. So really focusing on those things to help make them more independent. Carla also had mentioned in her discussion about with diabetic management, oftentimes one of the things that we're focusing on in therapy is making sure that they're able to draw up their insulin, check their blood sugars, those sort of things. And so that's another area that we're working on. And that's of course closer to when they're getting ready for discharge, but it is an important piece that we need to think about as therapists as well, to collaborate with the nurses to make sure that it's great that they know that they need to take their insulin and they know their levels, but if they can't draw up that insulin, or they can't administer the insulin, then we've got other issues too, especially if they don't have somebody at home that can help them with that. So thinking the whole picture of making sure that when they go home, they're able to do all parts, particularly if they don't have the support at home that to do that. So those are other components that we sometimes will work on. Also at this stage, we're continuing to address and becoming more aggressive with things like positioning. You know, contracture prevention is huge. We want to make sure that we're preventing any issues, long-term issues, if at all possible. So we're doing a lot of splinting at this stage. This is particularly with spasticity management, making sure that we're reacting proactively rather than reactively, if at all possible. We oftentimes will make sure that they have a consistent splint schedule. At this stage, we're monitoring for skin integrity issues. For those that have worked with individuals with stroke, particularly, one of the things that's not unusual to see is the fisting of a hand, and how we can have issues related to skin integrity, particularly pain, those sorts of things that can happen with that upper extremity. And so we really try to be pretty aggressive with that here to hopefully prevent those issues. And maintaining range of motion, but also teaching a range of motion at this stage. Self range of motion, you know, you're hopeful that you're going to get return, active movement return, but in the process of doing that, it's also teaching range of motion to the person served and their family's caregivers. It also gives them something to do. Sometimes they just want to do more therapy. They just want to be a part of it, and that's something. I mean, it can never hurt to have range of motion. So it's educating them and having them take charge of that a little bit too is a great way to help also manage your spasticity. And speech and language therapy intervention, there's lots of things happening here as well. The big thing I think that happens with a lot of our stroke individuals is communication strategies. Our speech language pathologists are really focusing on best ways for individuals to communicate their needs and wants, communicate with their families and friends. And that's an important part of all of ours, and it helps us feel connected and heard as well. Typically during this time, you know, there's a swallow evaluation, also a continuing in trials of different levels, self-feeding, all those things that are happening. It's not unusual that we, at some point, if they come to us on a modified diet, that they might have to get another swallow study just to verify that they're ready to move to that next level, that sort of thing. We also, and one thing I think we really focus a lot on here at On With Life is the education of our person served and families, and helping, you know, they've kind of had this, like we talked in the first acute hospitalization, they're in that life and death scenario at times. They're getting information thrown at them. They didn't think their loved one was going to survive. There's lots of things happening, and they're just in survival mode. So by the time they get here onto the next stage, we're really focusing on how do we help them understand what's kind of happened? How do we help them transition? And some are going to get it and some aren't at this stage. It's what they're ready for. But we really try to hit that hard while they're here, and give plenty of opportunities for education. And that could be also in not only stroke prevention, but about the stroke that occurred, what happened, where it was at, how that's affected different areas, what are the things they might be seeing. We're educating families and persons served on transfers and mobility. We're helping people be able to practice those things as well, so that they can start to do outings or transferring their person served as well, to increase that independence. And it could be even feeding, to be able to then sit down and for that loved one to be able to eat with their individual and sit and have supper and feel like they're confident in the person's abilities to eat safely, or get pleasure feedings. It's really about that education. And I think one of the things that we do in inpatient, I'll throw this back to Carla, is that we also have regular conferences with our person served, and really being able to make sure we're connecting and collaborating as a whole. So Carla, do you want to talk a little bit about your conferences?
Yeah, I'd be glad to. Thank you, Tammy. At On With Life, we really believe that the conference should just not be a report of how the person is doing. Because I know some places that's what happens. They're menaces with transfers. They're menaces with dressing. They're this, they're that. Oh, we have 2 weeks, and what's the plan to get them to home? Our families and persons served, the support network, are at the conferences, and we open the conference, every single one, including the first one, by talking about what are the goals. And folks have lots of goals, but usually their biggest and most important goal is they want to get home. They want to get back to their life. So we talk about that. We talk about how long we think we have to reach that goal. How long as professionals we think that they'll require this level of care. What amount of time they have with the insurance. Are those two things looking like they're going to come together or not? Because that's a problem if insurance is going to say no before they've reached their goal and readiness to be discharged. And then we talk about, as a whole team, from nursing and therapy and dietary and everybody involved in the care and treatment of the person served, how they're doing, what's going well, and what's still difficult, and how does that relate to discharge. Everything comes back to those goals and that biggest one of getting home. So are they still requiring 2 people for toileting? How does that relate for their transition home? So every piece of information that our clinical staff is sharing, we relate back to that. And then we also kind of have this frank and realistic discussion of, you're one person, it takes 2 to toilet. If that doesn't improve, is going home realistic or not? Or do we need a plan B? Well, we need another step between here and home. So just some really frank discussion about how much assistance and what that plan might really look like. And are you capable of helping the person served with this plan? Or do we have enough supports, to make that happen? Because it could be they do have enough supports and that plan is still realistic, and we just got to develop that plan a little better. After we have that discussion, whether it's continuing to work towards home, we have homework assignments then. So we actually give assignments to the person served, to the family, and to the clinical staff of what needs to be done. For example, one of the homework assignments for someone going home might be to do a formal home evaluation. One of the home assignments, instead of doing a formal home evaluation, might be for the person's wife to bring in pictures of the home and to measure the widths of the doorway and the space between the toilet and tub and those sorts of things. Another homework assignment might be that they need to work on administering their insulin, that they need to start learning to self-catheterize themselves. I mean, lots of homework assignments come out. From a case management perspective, it might be to sit down and talk to them about the different levels of care, just in case, because we're worried about needing a transition plan in place, what insurance covers, what would be an out-of-pocket cost, exploring support networks, informally and formally. Formally might be, if you hired someone, how much, what does that look like? Where do you go to? Where are the agencies if you're going to hire a companion in the home, for example? Informal support networks might be, have you talked to people at your church? Have you we could contact the local nursing school and see if there are any students there that would like to be privately hired to work in the home. So those are the kind of homework assignments that come out of our conference. And then we close to make sure that no one on the team has any questions about the plan. So that's how the conferences run. We need to talk a little bit about barriers here. And really the big barriers are that preparation for the family home. Are they stable enough to go to that next step, or will they need somewhere else? Where are they at in their coping? I have families that say, sometimes I just can't do anything else. And you have to actually walk them through every step of this. You need to call here. You need to ask them these questions. I can do this for you. You have to do this. I mean, you break it out into very, very concrete things because they're trying to learn a lot. They're scared. They're afraid. Their life has still changed forever. Their financial status has changed. And they just have a hard time coping still. They still might be in denial and disbelief still, even at this point that this whole thing has happened to them. So my message is help them as much as they need to get through these process. Let's see. Do you want to talk just a little bit about assessing for that transition home, or?
Yeah, so sometimes it's knowing where they are in terms of how much care are they going to require. Majority of the people that we send home from On With Life are still going to require that 24/7 care from a safety standpoint, and sometimes physical care. Not always. If they would discharge from acute rehab, are they going to need that level of care returning home? So what's happening a lot during this time is knowing the level of care that they're going to require, and that includes equipment as well. So that could include, are they going to need a hospital bed, a bed rail, a lift? Maybe they're going to need a wheelchair or shower bench, commode, toilet riser. So again, it's fully assessing, okay, if they're going to leave here and they're going to need this for care, what other additional supports are they going to need to be able to return home? And also then providing them of, okay, if home is not the next realistic step, what is that next step? If taking them home right now is too much of a burden, or they just physically can't take somebody home, then what are their options? Is it going to an assisted living? Is it going to a nursing facility that has longer term care? Is it hiring home health? So again, a lot of stuff happening at this stage of really determining where they're going from here. And again, as we mentioned in the first step, it's preparing that family for that next step in transition. Again, they're just wanting their loved one home, and they're just wanting them to stay. Oftentimes we get people that just want to stay here until they're able to go home, and that's not always realistic. We can't keep somebody here just because somebody wants to stay here. There's so many components going into play with insurance and needs and tolerance and all that. So again, it's helping them understand that this is an ever-changing process that they're going through. There's different level of cares. You're not going to be in that same spot the whole time, and this is what to expect. So always helping them look forward to the next step and where they're going. And that kind of leads us into the next slide, which talks more specifically about outpatient rehabilitation and what is happening here. It is a little bit different focus than we have been talking about. You know, in the inpatient and acute level, it's been so focused medically and getting them to the point where they can tolerate and participate and move through those stages. And in outpatient rehab, there's that really isn't the case from a medical standpoint. And Carla, do you want to talk a little bit about the medical part?
Yes, I'll be brief here, because the hope is at this point, Tammy, that the folks are medically stable when they're in outpatient therapy, that the medical management is taking a backseat now to the therapy, and they're very actively participating in that programming. I know that at On With Life, our outpatient therapy team makes sure that the person is still going to their medical appointments. They're seeing their primary care physician who's driving the care, that they're reporting any issues that they're having to that person, whether it be with skin or blood pressures or anything else. And any monitoring of ongoing medical needs is really a collaborative approach with our therapists, helping them make sure that they're reporting the right information to the physician, because the physician won't be able to help them if they don't know what are the issues are.
Yeah, that's a great point, Carla. There is a lot of collaboration happening at this stage. And yes, we're making sure the person served is also touching base with their physician, but we're in addition also calling that physician to make sure that the information is being correctly relayed, not that they're intentionally trying to give the wrong information, but not always does it get conveyed in the way that we need it to. So we're following up as well with that step and making sure we're collaborating with the other team members.
And I'd just like to add, Tammy, before you move on to therapy, that the focus really continues to be from the clinicians on prevention, because you want to prevent further blood pressure issues, diabetic issues, cholesterol issues. You're looking at weight management, preventing blood clots, smoking cessation, and again, all things that might be risk factors for a secondary stroke. And I know that here at On With Life, our therapists incorporate that into therapy, thread it in and out of the activities or tasks that they're working with our person served on.
Yeah, we're actually even doing that one step before they even start therapy. You know, one thing we do have here is we're able to have a care coordinator that is from the very start, from the moment they come in and we're doing intake paperwork, we are addressing those specific needs in this stroke population to make sure that they're being addressed and providing them information about those risk factors and the prevention and things that they need to do to help prevent another stroke from happening. So that's pretty typical in the processes that we have here. So anything else nursing wise, Carla, that you can think of? Okay, so from a therapy standpoint, what's happening here? Again, at this level, the focus really is highly on therapy and home living, that day-to-day life. From a therapy standpoint, an individual might need only one therapy, or they could still require multiple. There's no requirement for them to be at a certain level or need certain things for them to receive outpatient therapy. It's solely based on their need and what they're having difficulty with. It's not unusual when we get somebody that's had an acute stroke that when they come to us that they would get assessed by all three initially and require services by all three initially. That wouldn't be an unusual thing. The further we get out from stroke, they might be coming back for little tune-ups in areas that might only be one therapy. So if they're struggling with getting dressed, they might just come back for OT, or if they're struggling with return to work and it's based on cognitive stuff or communication stuff, it might be speech. So it varies greatly from an outpatient standpoint as to what therapies are involved. The big thing we're striving for at this level is that engagement and focusing on that engagement, what's important to them, what's meaningful to them. It becomes quality of life. What brings them quality of life is what we're focusing on in inpatient at this stage. For them, it could be that for them, it's so important to return to work. Maybe it's return to school or driving, whatever the case may be. What their goals is our goals, and that's what we're focusing on. How do we get them back to that? We do continue to assess their baselines, what differences that they're making, the progress that they're making. We're assessing and progressing mobility and ADLs. It's really about function. So with mobility, if they are walking with a device and their goal is to walk without a device, then that might be what we really focus hard on to get them to that next stage. And then fine tuning those things. So maybe they're ambulating really well, but they have a really weird quirk that we really want to focus on, and we're going to fine tune that. So we get that opportunity to really, as they get better and better and the progress is, and they're becoming more independent, we can then turn to fine tuning it. How do we make it look good? How do we make it move forward? That sort of thing. We're addressing safety and problem solving at this stage, particularly if they had gone home with, if they'd gone home with 24/7 care. Oftentimes what we're faced with in outpatient is helping that family transition of when's the right time to move on to less oversight and less care. And so we're working and collaborating with the family and the person served on that. We're trialing alternative methods of problem solving. So maybe what we initially set up at one level is no longer working, or they took it home and it didn't work. We're going to work with them to try to figure out a different setup. Maybe it's they're not remembering their appointments and they keep losing their memory book. So maybe, but they can always keep a hold of their phone. I mean, it could be something like that. Okay, so do we need to start utilizing their phone more for those reminders, or that ways for them to input that? So again, assessing what they're utilizing, assessing what their routines are, and helping figure out the things of where we could build in those helps. And then also there's so much happening at this stage. And the big thing I want you to hear is that we're really focusing in on that function, that daily life, that quality of life, and helping them reach those specific goals through the therapy. We're also doing a lot of education with person served and families. They're getting home programs, so they're going home with their exercises, and we're updating those programs to challenge them more after they've met those. We're sending them home with the things like their med protocols and their med management. How is that going? If we're getting feedback from families saying, oh, I helped them set up their med planner and they continually miss to put in the morning pills, or they're continually putting in the wrong thing, then we might switch our focus and now specifically target med management heavy again. In some cases, we have worked with self-cathing. How do we help somebody get to the point where they can self-cath and be able to be independent with that, or be able to, that could be what's holding them back from being able to go out into the community, is because they can't do that. So really focusing those skills on the techniques and strategies that they need to be able to self-cath. So again, those kind of things of how do we get them reintegrated back into the community, back into life, and having good quality life. And then it's constantly working with individuals on now they're confronted with a new hurdle, or they have a new goal. It's getting input back from them and working with them in a collaborative fashion to be able to help them problem solve. So that's really how we kind of approach a quick snapshot from a therapy standpoint in outpatient. Some of the barriers, let's just talk quick about barriers, Carla, is that that medical stability can at times be challenged a little bit, particularly if there's a new incident that occurs, they've fallen, they get a UTI. Those are the common things that we will sometimes see in outpatient. And so those things can affect their medical stability. And so it's helping kind of be proactive there, the things that we're noticing, talking with the families of what they're noticing, and encourage them then to seek out their physician, and talking with the physician and giving them a call or going to see them. It's surprising to me how little they want to go back to the doctor. You know, granted, they've been going to the doctor, had a lot of medical care in the last year, but when they get home and things aren't going well, or they're not feeling well, it sometimes takes a lot of extra push from us to get them to go back or to give their doctor a call. So the other thing we often are challenged with, particularly after an acute stroke, is stabilization of blood pressures. And so we're constantly providing feedback to person served and the physician of what we're seeing with that as well. We're also talking with families. Some of the barriers are things that we really try to have them prepare for, is the safety. It's not unusual for us to get reports of somebody's fallen, particularly in the middle of the night, or they tried to get up on their own because they thought that they could do it. And families just, even though we prepare them for it and tell them to expect that, it's kind of like real life has stepped in, and so it's walking them through that as well. Working with them of, do they have the right resources in place? We'll talk a little bit that on the next slide, Carla and I will, when we talk about case management, and where that family is in coping. And there can be significant concerns from a financial standpoint at this level. Now they're realizing that their person served isn't going to be able to go back to work as quickly, and the medical bills are starting to come in. And so that's kind of typically happening at this stage. So we're going to quick move to the next slide, which is discussing about case management. We're going to go over just a few quick things, kind of the points we want to drive home to you to take from this. And where we see the need of having a plan, identifying the needs and resources, advocating for a person served, and also preparing for the worst and hoping for the best is really kind of what we want to drive home from this webinar.
All right, Tammy, thank you. I'm going to talk just a little bit about the plan, and I think that we do a very good job at On With Life at all of our levels of care, really talking about what does that realistic plan look like? How much assistance does someone need? How much assistance can you provide? What assistance will we need to arrange to make that plan happen? How much supervision do they need? What do we need to arrange? How much support do you have in the family? Just a natural support that we can call in. Are there other community supports? Do we need a plan B? What does that next step look like? If we need a transition step between here and there, we try to set up more supports at first and then withdraw them as we know the plan is successful, because we want someone to not fall and not be confused and not have a stove left on and all those things that are potential hazards within the home environment. So we try to set up more supports and then wean those back as we know they're being successful.
I think one of the big things that we try to make sure that they try to understand, which still doesn't always sink in, is that the change in rehabilitation from inpatient to outpatient or from inpatient to going home, because they've been receiving so much more therapy at that level, and then they go home and they get outpatient or home health, and it's kind of a shock to them. So we really try to help prepare them that really this next step is about getting on with life, and they'll return to work and school and home programs, and that they're going to get less formal therapy, but their therapy has now become their daily life. So the next thing we really try to do is identify needs and resources. So what community are they in? What do they need? What is available? What do they qualify? We're always talking amongst and collaborating amongst staff of what are the options out there that could be appropriate for this person. It could be community groups. Are there social and physical groups going on that would be great for them to get involved in? Do they need financial assistance? Do they have daycare options or respite care options? The outpatient therapy, support groups. So just looking at everything that's in that area. And like Carla says, we try to make sure that they go home with a lot of options so that they know what's out there as well. Then we're looking at additional resources such as, those resources could be people. It could be that financial resource. It could be housing. Maybe it's the Medicaid, maybe it's a waiver, maybe it's transportation. There's so many different things that we're helping to look and identify with what's in their community to assist them. And from an advocate standpoint or communication standpoint, Carla, do you want to talk a little bit about this? Yeah, sure.
We encourage a person served and their families to advocate. We want them to ask questions. We encourage them to speak up. We don't want their voices to go unheard. We don't want questions unasked. We want them to speak up if something doesn't feel right. We want them to ask about it. If they don't understand, we want them to continue to ask, that they tell us, we don't understand yet. We know that people can only take in so much information, even if you've told them the whole gamut of it. We want them to ask what services are available. What do I qualify for? So we would prep them. Not only do we educate them, but every time they're interacting with a new service, we want them to make a list of things that they're wondering about, struggling with, that they need help with, and ask at that agency, can you help with this? Can you also help with that? Just run down the whole list of questions that you have. The other thing that's really hard for people is to ask their friends, ask their families, ask their church families for help. And we really prep them, even role play it sometimes. How do you ask? And we know from being in the field so long that there are people in their support networks that often want to help, but they don't know what to do. Mm-hmm. And if you ask them, gosh, I need to go shopping once a week to get groceries and I need someone to be with my husband, could you come be with him for these 2 hours so I can make sure to run my errands and get my groceries and get back home? And often people will jump at the chance to help. It makes them feel fulfilled to know that they're giving back to someone that they care about. And one of the things that I encourage at every level is that we also challenge insurance. If we feel like the time is not right, whether the person served themselves or us, we encourage to push back, to provide the education of why they still continue to need this service, to appeal any decision that the insurance makes, whether that's formally through appeal letters, peer-to-peer reviews from physicians, whether that's informally that the person calls up and says, who can I talk to? I just want it noted that this didn't feel right. Ask if there's a case manager at the insurance that can follow me in the community to help me find services for these things that I still need help with, whether it's transportation, I don't know, more help coming into the home. And then On With Life actually takes that a step further, and we provide formal education at different insurance companies. For example, recently I was involved in an education lunch and learn at Blue Cross, where we talked about there are two components to recovery. There's the physical component, how well can I walk, but there's also the cognitive component. How well can I remember to sequence how I walk? How many cues do I need? So someone may walk with very little assistance, like minimal assistance, but they might need maximal cues to make sure that that gait technique is being followed correctly. So you're actually measuring two components. You can't take one measurement. It takes two to make that happen. So you got to look at that physical and cognitive ability together.
Yeah, I think that's great, Carla. I think I just want to throw in there from an outpatient standpoint, one of the things we often can fight for is with insurances, there is also many from an outpatient standpoint that have a hard cap or a soft cap. So we oftentimes, if they have a soft cap, can continue to advocate for more services. So that's the only thing I would add in outpatient. So I think the last thing we just want to say, and then we'll throw it back to Dave, is that really it's about preparing for the worst and hoping for the best. Having that person in the right place and the right time and getting the right services is really what our goal is and really what we're focusing on. Would you agree, Carla?
I do.
Yeah.
Nicely said.
All right. So Dave, we're throwing it back to you.
Thanks, Tammy and Carla. And why don't we transition into the Q&A segment of today's webinar? I see that we have several questions that have been submitted, so let's jump right into this. This first question is from Bill. With insurance, there's a need to show functional progress, says Bill. How do you typically manage the insurance to maximize coverage?
So from an outpatient standpoint, again, it kind of throws back to what I just mentioned to in the previous slide, is that many policies in outpatient have soft caps. So that just means you can ask for more. The worst that they can always say is no. So I always say, let's go for it. Let's ask for it. If we have the medical necessity and can show it, then let's do that. And if we get formally denied and the person served really the therapist feel, then we can go into bat maybe of specifically trying to do a formal appeal if necessary. And we've done that a few times and been able to overturn the appeal to be able to show the need for the additional services. Carla, do you have anything specific you want to throw in there?
Yeah, on an inpatient basis, what normally happens from the insurance perspective is that we give them weekly updates on someone's progress and why they continue to require to be inpatient. And we do a lot of education every week with case managers on that person served, on why they continue to require continued inpatient treatment. And so we might be having a dialogue about why the balance is so important for this person. Because they have to be able to be alone for a few hours a day, because they have to be able to toilet themselves, because, and why the balance is so important for those certain activities that they have to do. So really, we would say even though they can transfer in the moment with a therapist with this amount of assistance, minimal assistance, they still have to be able to do that with their balance. And we just continue to provide why we really have to look at certain components before we can discharge them. We're pretty successful with that if you can lay out the full story of where we're going, what the goals are. And again, formally, if we would have a denial before we feel, from a medical standpoint and a rehabilitation team standpoint, that someone's ready, we would do those formal peer-to-peer and appeals letters to try to advocate for that person if they weren't ready to go yet.
All right, this next question is from Marie. I think this is a good follow-up to that first question. Marie wants to know, how do you keep people motivated or get people motivated to improve participation in therapy and keep their insurance companies happy?
Thanks, Dave. I'd be glad to start that conversation. From an inpatient standpoint, insurances just look at certain markers. They're looking at things like how well does someone transfer? How well does someone walk? How well does someone dress? They really don't necessarily care about how you go about getting them to do those things, which really leads nicely into that discussion Tammy was having about engagement. So I'm going to pass to you, Tammy.
Great. So maybe the best way I can show this is kind of taking an activity and breaking it down. So you're really wanting to know how somebody's doing, like, are they mid-assist? Are they mod-assist? They walk this far. So how we might get that in therapy without making it seem like therapy, let's take that we have a gentleman who he really is just kind of doing the bare minimum in traditional therapy sessions, but we take him fishing because to him, fishing is his whole world. He loves to fish. And so this is how we might get Carla's answers, but be able to do something that to this gentleman is meaningful and engaging. And so, okay, we've taken him fishing. Well, in order to get him to go fishing, we've got to work on car transfers. We've got to get him in and out of the car. So we're able to give Carla some idea on how he's doing with transfers, if that's better. Getting in and out of a boat. How does he move on those moving targets? Is he able to do that safely in and out? We might be then in that process training on those techniques of how to do those transfers. Again, from an insurance perspective, we're training on the transfers. We're training the techniques for the family. We're training and focusing on independence for that person served. Again, the bigger picture here is that it's for quality of life, but we're still getting the answers that Carla needs from a functional standpoint. Now, while we're on this outing, we can work on ambulation if it's appropriate. So not only do we now have just a standard surface that you typically get in a building, but we can now work on multiple surfaces. There's gravel, there's grass, there's hills. Heck, we can go down a bank. There's moving surfaces if they're getting into a boat. So now we've put an additional challenge to the ambulation that we can report how they're doing on those different services. We can address balance. You know, when you're standing, you could stand and hold a fishing pole. You could cast, and then hopefully you can net something and take the hook out. So you have all those things happening that are going to require divided attention while maintaining their balance. And then even just bending down to get that worm out of the bottom of the bait bucket to be able to put on. I mean, there's all those components that, again, you can report on balance with static balance, standing or dynamic balance, those kind of things. Then you can look at the ADLs even. I mean, if you think about it, what happens when you're out in the woods and you gotta go? So there's porta potty transfers that you can teach, or roughing it in the bushes. I mean, there's plenty of options that you can work on to be able to get those ADLs thrown in there as well. The additional benefits of something like this engagement and getting Carla the information she needs for insurance is you can discuss fine motor coordination, gross motor coordination, what's their reflexes like, that eye-hand coordination, how's their cognitive skills, were there problem solving, sequencing, planning. You know, you've got all that stuff happening that you can take that activity that truly engages him and be able to still pull out of it and break it down, the stuff that Carla needs. And that's quality of life. That's stress reliever. That's laughter therapy. That is really what engagement is, and what I think sets us apart in being able to do those things and still be able to break that down and get insurance the information that they need.
I think we have time for one last question. This one's from Grace. How do you manage care when individuals are medical complex or have medical issues that limit participation in rehab?
That's a good question, Dave. I'll start answering that. And that's huge when someone originally comes out of acute care into a rehabilitation inpatient program, because they're still fragile. They've not been out that long from the event, from their date of injury. They haven't been in the hospital that long usually, and they're going to an intensive rehab program, which additionally stresses the body. And sometimes the medical plan does outweigh the therapy plan in that they're just fragile and sick. And some of that does lead to them just being down in bed for some time, whether it's part of the day, a whole day or two. What happens then with therapy in the inpatient program, you do what you can from the bed. You certainly can still work on cognitive functioning if they're, or communication functioning if they're alert and still able to do that. You continue to do the basics, the range of motion, that sort of thing. And if they can sit up on the edge, you're still working on balance. I mean, there's lots you can do from the edge of the bed, even though you're not going full bore in a therapy gym. The other thing from a case management perspective is that you explain that to the insurance. We hit a bump in the road. Here's what happens this week. Here's what we're thinking is the extent, how long it's going to take to recover from this. This is our plan. This is the medication changes. This is what we expect for next week. And most insurances will let you hit a bump in the road. Now that bump in the road can't continue forever, but as long as you have a good medical plan and you're able to convey that to the insurance, you'll usually be all right and can move past it as they recover. And you hope as their medical status improves and they become less fragile that that therapy component just absolutely blossoms and they're able to move on to more intensive therapy days.
From an outpatient standpoint, I'll just kind of end with that. We're not necessarily as involved in that medical component of care, but we are collaborating with all those involved in the care. So that could include the person's or family as well as a physician. So for instance, if somebody's coming to us for therapy, but we've been noticing that their blood pressure has been extremely high, and every time they're coming in, it's their blood pressure is higher. They're consistently canceling because they can't get their blood pressure under control or not feeling well, or maybe medications are being changed. Then that might be, well, that's at the point where we're collaborating with everybody involved in determining what's best. So are we putting on somebody on hold for a week? Are we discharging at this point? Are they changing level of care? Do they need home health until they're more stable? So really it's, again, assessing in that moment and making decisions based on that.
All right. Well, I think that is just about all the time we have for today. Thank you so much, Tammy. Thank you so much, Carla, for all of your insights today. Again, as I mentioned at the start of the webinar, if you missed any of the earlier webinars in this series, all of them are available on the On With Life website. There's no cost to view any of the webinars, and each webinar is good for 1 contact hour of continuing education credit. After you viewed a webinar, just complete the post-webinar evaluation form to receive your certificate. Thanks so much for being with us today. We really appreciate it. That does conclude today's webinar. Have a great day.